Hello all, week 6 here, and we're going to be talking about blood. Blood cells with a specific focus on red blood cells and platelets, and then we're going to talk a little bit about blood clotting and diseases of blood clotting. Here are your reading assignments. Please note that it's coming from 4 different chapters, but you only got some select areas within those chapters to take a look at. So here we go. So what is blood? Blood is actually a collection of cells and plasma. Cells account for just over half of total blood volume. In a healthy adult, you've got about 5.5 liters of total blood, and 3 liters of that is plasma. So what is plasma? Plasma is the fluid component of blood. You all know that if you took blood and put it in a tube and allowed it to coagulate, it would quickly partition into 2 layers, the cellular layer and the fluid plasma layer. And if you looked really close, if you actually centrifuged it, that cellular layer would actually go into 2 separate layers, one layer which contained the red blood cells, which would sink to the bottom, and then the lighter layer, which is a combination of the white blood cells and the platelets. It's in plasma then, in the fluid component of blood, that you have the dissolved water-soluble products such as the proteins, the solutes, the lipids, etc. And when you run a blood test, for the most part, what they're doing is they're running it on plasma. A lot of the blood testing is actually run on plasma, particularly when you're looking at dissolved contents in blood. You've interpreted and seen hundreds and hundreds of blood tests. These are just examples of the different electrolytes and enzymes and proteins and the different chemistries that you can get in blood or plasma. We will talk more about lipids in the cardiovascular unit. Again, another test which is run on plasma. Look down at the left there and you can see that blood has been partitioned really nicely into the plasma layer, the white blood cell platelet layer, and the red blood cell platelet layer at the bottom. And if you look at the tube with the red arrow, you can see that that plasma kind of looks like custard or tapioca, very cloudy, very dense. This would be an individual who has lipemic serum or a high amount of fat due to some type of lipid disorder. And again, hold on, we'll be talking about that stuff in the cardiovascular unit. But what I want to focus on this week are the blood cells. And as you can see here, we've got a number of different types of what we're going to call mature blood cells. Remember, these blood cells are developing in bone marrow as immature precursor cells, and then once they are maturated and differentiated, then they're released into blood. And they all have varying half-lives in terms of how long they hang around. The red blood cells hang around for the longest time, about 120 days. Platelets, less than a day. So bone marrow has to constantly be churning out mature blood cells because the blood cells that we have in blood out in the periphery only have a finite period of time in which they live and are functional. One of the most common exams which is done on blood is the CBC with differential, where the lab techs are identifying the total number of each of the varying blood cells and then giving you some report on the visualization of their morphology or what they look like. Do they look like normal blood cells? And then here is an example of a CBC with diff with the varying results for each. We'll be talking mostly about the red blood cells, the hematocrit hemoglobin, the reticulocytes, a little bit on the white blood cells, and a little bit more on the platelets. And remember, these are all these values come in some type of homeostatic range, and we all vary. Numbers vary by age, numbers vary by gender. On any exam or quiz that I give you, if I give you a lab test, including a CBC, I will always give you the normal ranges. You know that after a while, if you've been in the business for a while, you start to recognize it just. And then here is what I mean in terms of morphology. So not only do you get the numerical values on a CBC, but then they will plate that out on a slide. They'll stain it, and then they will look at these blood cells and give you their interpretation of their morphologies. So the red blood cells are the most abundant. Those are the ones that look like little red donuts with the clear center. The white blood cells are the large ones. They look very granular. You can see a number of different white blood cells in there. And then the small kind of faded out purple dots, the smaller cells, those are the platelets. So how do we differentiate these cells in bone marrow? So in bone marrow, we're going to have a number of cells which are referred to as a pluripotent hematopoietic stem cell. What does that mean? These are early precursor cells that have all the DNA necessary to turn into any one of the mature blood cells. How they do that is all dependent on which growth factor and which hormone they are exposed to. So you take a pluripotent cell, and the first thing that's going to happen, it's going to differentiate into one of two cell lines, a lymphoid line, and then that stem cell becomes a lymphoid stem cell, and it will be destined to become some type of lymphocyte, a B cell, a T cell, or a natural killer cell. Or the first stage may differentiate into a myeloid cell, and then from that myeloid cell it has the opportunity to become any one of other white blood cells, a platelet, or a red blood cell. Interesting thing about the platelets and the red blood cells is once they are released into plasma, they lose their nucleus. They lose their DNA, so they have now lost their ability to copy DNA and divide. So platelets and erythrocytes are anuclear, A standing for without a nucleus. And how they differentiate is all dependent on which growth factor they are exposed to. If a pluripotent stem cell is going to become a mature red blood cell, they are going to be exposed to, and they are going to differentiate under the growth factor referred to as EPO, erythropoietin. And then you can see there in the graph numbers of other growth factors which drive the differentiation to one of the mature cell lines. So what is erythropoietin? And we're going to start talking about the red blood cells first. Erythropoietin is a hormone. It's a protein synthesized by the kidney, released into blood, and then stimulates the growth of red blood cells in bone marrow. Fits our definition of a hormone. Synthesized in one organ, released in bloodstream, has its effect on the other organ. The one thing that we see with erythropoietin, it is not under the control of the pituitary gland. So think back a couple of units when we talked about the pituitary gland. This one has nothing to do with the pituitary gland. And then there you can see the large protein structure of erythropoietin with its sequence of amino acids. Again, don't memorize that sequence of amino acids. And then we have erythropoietin as a pharmaceutical product. So now as a synthesized recombinant human erythropoietin, we can give individuals shots of erythropoietin, particularly individuals who have failing bone marrow and are not pumping out adequate amounts of red blood cells. Classic example is an individual who is suffering from cancer, receiving chemotherapy, particularly receiving some of the non-specific chemotherapy. And as you recall, a lot of that non-specific chemotherapy not only kills the cancer cells, but also kills other rapidly dividing cells, including those immature cells of the bone marrow. And if you've taken care of cancer patients, you know that they are at very high risk of anemia. They very often require red blood cell transfusions and almost always require some form of erythropoietin supplementation to maintain adequate amounts of healthy red blood cells. So let me pose this question to you. Why do you think certain athletes have themselves injected with EPO? That's referred to as athletic doping, or sports or performance enhancing through drugs. This is illegal in most professional organizations, including the Olympics. Consider why an athlete may voluntarily choose to subject him or herself to EPO injections. Okay, let's talk about the red blood cells. You can see these are the ones that are red. They kind of look like little donuts. They're concave. Again, they've lost their nucleus. That concave nature to them gives them a very high surface area. They are loaded with a protein called hemoglobin. And hemoglobin is going to bind the oxygen, and that is the one job of the red blood cell, is to carry oxygen around the body. They live for about 120 days, so again, there's got to be this constant turnover and synthesis of the new red blood cell. Some immature red blood cells, which still have remnants of a nucleus, can be found in plasma. Those are referred to as reticulocytes. You can see pictures of some reticulocytes in the lowest picture at the arrow. And if you have a reduced number of red blood cells, you don't have enough red blood cells in blood, then that's a condition referred to as anemia. Within the red blood cell is the hemoglobin protein, and the hemoglobin protein binds the oxygen. So when I say a hemoglobin protein molecule, that molecule is made up of 4 distinct protein chains referred to as globulin chains. And in each of those chains, centrally located, is going to be a heme ring, also referred to as a protoporphyrin. And if you look at that heme ring, you see it's pretty complex looking hydrocarbon with a lot of nitrogen in it, and in the middle of that heme ring is an iron molecule. The oxygen atoms, the O2 atoms, are going to bind to that iron molecule, and each iron molecule binds one O2 molecule. So if we have 4 chains, each with a protoporphyrin, one big molecule of hemoglobin will bind 4 O2 molecules. The chains differ, but for the most part, most individuals have 2 alpha chains and 2 beta chains, and we'll talk a little bit about variation of those chains as we move on here. The hematocrit, you have all seen hematocrit values. The hematocrit is the percent of blood attributed just to red blood cells. And again, red blood cells make up the largest portion of blood. Hematocrit varies by age, by gender, by altitude. Typically, if you live at a very high altitude area where oxygen tensions are lower, you tend to have a higher hematocrit. So an individual living in Denver, Colorado, probably going to have a higher hematocrit than an individual living, say, in Miami, Florida, right at sea level. If you took some blood and you put it in a small pipette tube like this and centrifuged it and it would layer out, you can see what portion is the plasma, what portion is the red blood cells. So what would you estimate this individual's hematocrit to be in terms of a percent? And then do you think that individual is anemic, yes or no? What do you think? I probably estimate something a little less than 40%. And I would say, yeah, this person looks like they have anemia. All right, so the hematocrit is a measure of the percent of blood attributed to the red blood cells. You can see the different ranges there by male versus female gender versus child versus an adult. It is the monthly loss of red blood cells during menstruation, which make the hematocrit values in women of childbearing age a little bit lower than that of age-related males. So you can measure the hematocrit. You can also measure the hemoglobin protein. So when you get a hemoglobin measurement, they're measuring the amount of hemoglobin protein per 100 mLs of blood. And again, you can see the typical values of hemoglobin for individuals as well. Put the two together, and that's referred to as the H and H. And they are directly proportional. When one's low, the other is low, and it's all dependent on the amount of red blood cells that the individual has. So if your total red blood cell amount is low, your H and H are also going to be low. Important to realize, and when we measure hemoglobin protein, we're measuring the total amount of hemoglobin present in the red blood cells. Okay? Hemoglobin protein is found in the red blood cells. It typically does not exist free in plasma, meaning it's not outside of the red blood cell floating around in plasma. That's actually a relatively dangerous condition, and that can lead to renal toxicity to have hemoglobin free in plasma. So when we're measuring hemoglobin, we're measuring what's in the red blood cell. And again, like I show at the bottom here, here is a goofy question for you. In order to properly synthesize adequate number of circulating blood cells, do you need to be wearing nice ironed clothing? Do you need to be friends with Iron Man? Do you need to cook your food in an iron skillet? Or do you need to have some type of dietary source of organic iron? What's the answer here? Yeah, you need iron in your diet in order to make healthy red blood cells. Again, iron is a critical component of the protoporphyrin molecule found on the globulin chains in protein, and without having that iron, you're not going to make adequate numbers of healthy red blood cells. So it's considered to be an essential nutrient. We absorb iron from the diet, and then that is bound in plasma to a protein called transferrin. Transferrin protein transports iron around the body. Iron can be stored in the liver on a protein called ferritin. In fact, there's a couple of different places that we find ferritin, but it is primarily found in the liver. Remember, iron kind of has a rusty appearance to it. So when you look at a live liver, and we'll be looking at livers in the GI unit, it kind of has that rusty red appearance to it. That's due to the ferritin protein. We do not metabolize iron. The only way that we lose iron in the body is either we don't absorb it and it comes out in feces or bile, or we lose it through bleeding. And then you can see the distribution of iron. Most of iron then is on hemoglobin. Some of it's stored as ferritin. Some of it is in a molecule that we find in muscle, which carries oxygen, myoglobin. And then we find iron in other enzymes in the body, enzymes referred to as the cytochrome P450 system responsible for drug metabolism. Those enzymes also have iron molecules on it as well. So where do we get iron? We should be taking in about 10 to 15 milligrams per day of iron. Iron is relatively difficult to absorb out of the GI tract. There's an active transport mechanism that brings iron out of the lumen and through the small bowel epithelium. We get iron from meats, fish, poultry, eggs, beans, soy, and green leafies such as broccoli and spinach. A lot of things there that kids don't like to eat, right? Young, picky eater kids who like to eat things like peanut butter, jelly sandwiches, French fries, drink a lot of milk. Those kids are setting themselves up for iron deficiency anemia. And if you look at milk, there is no iron in milk. I've always kind of chuckle a little bit when I make a diagnosis of iron deficiency anemia in a child, and usually one of the first things a parent says, well, how can that be? He drinks 3, 4, 5 glasses of milk a day. Yeah, there's no iron in milk, and if you're not eating dietary foods that have iron in it, you're going to end up with iron deficiency anemia, particularly as a child. And you know that you can look at the nutrition label of just about anything and see what's all in there. And then one thing that you can pay attention to is how much iron are you getting per serving of whatever food product that label is for. So pay attention to that. 2 other critical nutrients necessary for red blood cell production is folate. And you can see that a lot of dietary folate comes from grains and vegetables and fruits. Right now, just about every grain product is fortified with folate. And it's hard to find a grain product, be it a bread or a cereal, that has not been supplemented with folate. So everybody, for the most part, no matter what type of diet you have, unless you're not eating, you got some disorder like anorexia, etc. Tough to find individuals who are deficient in dietary folate. Use the Lucky Charms example there, and you can look at its nutrition label, and you can see that that has been folate supplemented. Another critical nutrient is vitamin B12, a little bit more complex molecule. Vitamin B12 is primarily found in animal products, meats, poultry, seafoods, dairy, including cheeses and milk. So one can potentially, on a very strict vegan diet, one can potentially be deficient in vitamin B12, and that might be the one product that an individual on a very strict vegan diet probably ought to be considering to supplement, is with vitamin B12. I know that there are certainly some fruits and vegetables that you can get B12 in, but for the most part, that's coming from animal products. Individuals who suffer from pernicious anemia have an inability to absorb B12 from their GI tract, and therefore they're dependent on vitamin B12 injections to correct the anemia that they develop. We'll talk a little bit more about pernicious anemia when we get in the GI section and talk about what is it about the GI tract that doesn't allow certain people to absorb vitamin B12. So if you're deficient in iron, deficient in folate, deficient in vitamin B12, you are setting yourself up for inability to synthesize healthy red blood cells, and then you end up in a state of dietary anemia. Okay, more about red blood cells, what happens when they die. Again, they live for about 120 days. Dead red blood cells are primarily cleared in the spleen. Look at the picture of the CT scan, and the white arrow is pointing you the location of the spleen in the left upper quadrant, kind of to the side and behind the stomach bubble there. The hemoglobin will be released and metabolized to bilirubin, And then that bilirubin, a yellow stained pigment, is either excreted in the bile or excreted in the urine. Individuals who have inability to metabolize and excrete bilirubin, individuals who are breaking down their red blood cells far too quickly, that bilirubin may build up in the body and cause a yellow staining of the skin and the sclera, referred to as jaundice. I know you have all seen jaundiced individuals. When you see a jaundiced individual, two things that you should be thinking of is, are they jaundiced because they have liver disease and they can't break down and metabolize the bilirubin, get rid of the bilirubin, or are they jaundiced because they are having excessive breakdown of the red blood cells? And we're going to look at that process referred to as hemolysis, breakdown of red blood cells, as we move on here. Okay, anemia is a lower than normal number of circulating red blood cells that results in a lower value of your HNH, hematocrit, and hemoglobin. Red blood cells are our oxygen carrying cells, so therefore individuals who develop anemia develop signs and symptoms due to a lack of circulating oxygen. Most common initial symptoms are going to be fatigue, particularly with exercise or exercise intolerance. Shortness of breath, they start to look pale. Oxygenated hemoglobin is what gives us a nice pink color to our skin, to our mucous membranes. Individuals will develop elevated heart rate, tachycardia, and can actually develop syncopal episodes and pass out due to severe anemia. And when very extreme O2 carrying capacity is markedly inhibited, and that can lead to cardiovascular collapse. So the lower the H and H, the more likely the individual is going to have more profound symptoms of anemia. Now think of this question for a second. Who has a quicker clinical decompensation? An individual who has very rapid anemia or an individual who slowly develops anemia over time? Yeah, it's definitely the chronic, slow developing anemia. Those individuals tend to tolerate it better versus somebody who becomes very acutely anemic over a short period of time. How do you get anemia? There's three primary causes of anemia. Either you are losing red blood cells because you're hemorrhaging, you're not producing red blood cells due to something happening in bone marrow, or you're destroying your red blood cells within the body, and that's referred to as hemolysis. Let's look at each. Loss of blood. Okay, that's simple. You see somebody bleeding, hey, you're losing a lot of blood, you're losing red blood cells. Keep losing blood, you're going to get anemic. Keep losing blood, you're going to clinically decompensate and die, right? You're losing your O2 carrying capacity. So it's usually pretty apparent in an individual's history and physical exam if there's blood loss, right? The morphology of the red blood cells is usually normal. The reticulocyte count, so your body is if you're losing blood, your body is trying to make more red blood cells, so your reticulocyte count should be okay. You're not hemolyzing red blood cells, so your bilirubin level should be all right. And unless the bleeding is readily apparent, you know, slashed wrist, gunshot wound, something like that, the other places where you got to look for loss of red blood cell is the GI tract of males and females and the genital urinary tract in females. Destruction of red blood cells is hemolysis. That usually is apparent on the red blood on the blood smear because the red blood cell morphology is very abnormal. You get a bunch of fragmented, broken red blood cells that the lab tech should report for you. Same thing here. The problem is not in the bone marrow, so your reticulocyte count should be okay. Your bone marrow is going to try to be pumping out cells, so it's going to be releasing some of those immature nucleated reticulocyte counts. If you're pumping out if you're breaking down a lot of red blood cells, you may overwhelm your ability to metabolize the bilirubin, so bilirubin levels may go up Individual will get a jaundiced appearance. And you can measure hemoglobin in plasma. So again, hemolysis is the destruction of red blood cells. That's going to result in some release of hemoglobin into plasma, and you can measure that. Typically, we don't have hemoglobin free in plasma. And then another important cause of anemia is you're not making the red blood cells. There's a lack of synthesis. Something is happening in the bone marrow. You're not making those precursor cells, therefore you're not making adequate number of mature cells. These individuals typically have a low or absent reticulocyte count. A lot of different etiologies can lead to bone marrow failure. We'll talk about these as we move on. Individuals who are deficient in one of the three critical dietary nutrients, they become anemic due to a lack of synthesis because you don't have that nutrient necessary to make the red blood cell. Bone marrow can be overwhelmed by sepsis. It can be overwhelmed by infection. It can be overwhelmed by infiltration with cancer. It could be shut down due to drugs such as chemotherapy. So a lot of different reasons why bone marrow may fail. So you can look at this table here, and you can use this table to help you out make a diagnosis of why an individual is anemic. And helpful things that you can look at, so you look at the H&H. If the H&H values are low, you say they're anemic. So anemia is diagnosed based on the hemoglobin and hematocrit values. And then the next thing you want to do is you want to determine, are they losing cells? Are they destroying cells? Are they not synthesizing cells? And the reticulocyte count, the bilirubin level, and what the blood smear looks like are all very helpful in making that diagnosis. One other thing that you can look at is what's called the MCV, the mean cell volume, or how big or how small those red blood cells are. So if you find out that it is a synthesis problem, then you look at the MCV. Individuals with iron deficiency have a very low cell volume. Individuals with B12 or folate deficiency have a very high cell volume. And the lab techs will be able to tell that to you. The two slides here, the upper slide, are examples of cells which are microcytic, low cell volume. One cause of that is iron deficiency. The lower slide there, you see the cells look a little bit bigger, a little bit fatter, a little bit juicier. That's not necessarily normal to have big globular red blood cells like that. That's referred to as macrocytic. Causes for that can include either B12 or folate deficiency. And again, you're relying on your lab technician to make those reports for you. Blood loss and anemia, right? So someone gets stabbed in the chest, shot in the chest, slashes their wrist, puking up blood. Yeah, that's pretty easy. Pretty easy to determine why that individual may be anemic. But also remember, people can lose blood from the GI tract slowly from things like stomach cancers and colon cancers. Those individuals usually show up guaiac positive, right? Presence of the heme of the iron in the GI tract when you check their stool. And then women can lose a fair amount of blood due to menstrual disorders. So in a woman who is anemic, you got to do a very, very good menstrual history in terms of how often they're bleeding, how much they're bleeding. And I'm going to leave the menstrual disorders for your women's health class. I'm really not going to talk about those in any detail at all, other than to make sure that you realize that disorders of excessive menstruation can very rapidly lead to anemia in women. Another slide on the dietary factors, iron and vitamin B12. Interesting thing about both of these is if you're deficient in iron or deficient in B12, you can get swelling of your lips and gums, referred to as glossitis, swelling of the gingiva. stomatitis, swelling of the oral mucosa. But it is the cell volume, microcytic for iron, macrocytic for B12, that can lead you one way or another. An individual who's deficient in iron then is going to require some form of iron supplementation. Individual found to be deficient in B12 going to require some type of B12 supplementation. Remember, some people with certain GI disorders will not be able to absorb vitamin B12, therefore they're going to need vitamin B12 IM injections. Okay, what is hemolysis? Remember, hemolysis is the destruction of red blood cells in the body. That will lead to a low H&H anemia, result in elevated bilirubin levels because now you're suddenly overwhelming your body's ability to metabolize and get rid of the bilirubin coming from the breakdown of the red blood cell. The bone marrow usually not adversely affected, and the bone marrow is going to try to compensate by pumping out more cells. When it tries to pump out more cells, the reticulocyte count rises. So there's a clue to hemolysis, jaundice with elevated reticulocyte counts. And hemolysis can happen due to so many different things. There could be something wrong with the red blood cell. The cell membrane is defective. The hemoglobin molecules are defective, such as what you see in sickle cell anemia. They may have deficient enzymes which are necessary for detoxifying oxidizing agents which are exposed to. So people who have what's called G6PD deficiency, not an uncommon disorder at all. Those individuals have inherent pathology of their red blood cells, which makes them more prone to hemolysis. Another reason people might hemolyze is due to what we refer to as an extrinsic factor. The red blood cells themselves are normal, but they're being exposed to something which is causing them to rip up the red blood cell. They may have an autoimmune disorder called autoimmune hemolytic anemia, where they are creating self-antibody against their own red blood cell, and those antibodies are destroying the red blood cells. Certain microorganisms cause hemolysis. Malaria is notorious for causing severe hemolysis. Other disorders that we're going to look at towards the end of this unit, DIC, hemolytic uremic syndrome, can cause hemolysis. Being exposed to certain types of toxins. If you are bit by certain animals, particularly rattlesnakes and brown recluse spider, in their venom are proteins that can actively destroy red blood cells. So a lot of different things, and making a diagnosis of hemolysis is not that difficult. The difficulty is trying to figure out why is this individual hemolyzing the red blood cells. So you got to look at a number of different things. Is there something inherently wrong with the red blood cell, or is it something that they've been exposed to, or is it autoimmune by nature? And here are some peripheral blood smears where you see some normal appearing type red blood cells, right? That concave, centrally cleared, nice, healthy looking red donut. But then you look at all these 4 slides and you see the fragmentation, right? And if you look really close, particularly in the upper left side, can you see the reticulocytes in there? Can you see the red blood cells that still have some remnants of a nucleus? Those are the reticulocytes. So that's a nice photo. It shows you not only fragmented cells, but cells with very abnormal morphology, but also showing you some reticulocytes in there as well. The bottom right slide, see that big abnormal cell in the middle there? Kind of looks like a long sickle. What do you think that individual suffers from? Yeah, there you go, sickle cell anemia. It's a disorder where the hemoglobin molecules are abnormal. leading the cell to have an increased risk of being torn apart or hemolyzed. So the inherent disorder there is on the hemoglobin protein. Okay, now I have 5 cases for you that I want you to look at, and then you can comment on Blackboard about each of these cases. I give you a little scenario. I'm going to show you their blood smear compared to a normal blood smear. I want you to answer the questions and then see if you can come up with a diagnosis. Are they anemic? And then can you come up with why are they anemic? So if you say they're anemic, now the first thing to do is look, is it loss, destruction, or synthesis? And then see if you can come up with a reason after that. So here's Mary. She's got an eating disorder. Here's Tara. She appears to have some type of menstrual disorder. Here's Paul. He had some kind of virus infection. He's a young child, had a virus infection. Now he seems to be pretty sick. Here's Jerry. He was markedly overweight and he had gastric bypass surgery, had the majority of his stomach removed. Here's Jane. She was treated for a urinary tract infection with 2 different medications, nitrofurantoin, an antibiotic, and pyridium, a drug which is used as kind of like a pain medicine, kind of helps anesthetize the bladder so you don't get really bad dysuria. And now after her urinary tract infection is cleared, she feels short of breath and she's jaundiced. See what you can come up with her, okay? Okay, a little bit of pharmacology now, and specifically with iron. If you look at vitamins, you can see that all vitamins are not the same in terms of their iron. Men, for the most part, do not need iron in their vitamins. In fact, it's been shown that too much iron in men can increase their risk of cardiovascular disease. Women need the iron, particularly women of childbearing age, because monthly they're losing iron in menstruation. Men don't do that. So you look at the difference between a woman's multiple vitamin and a men's multiple vitamin, you see men's typically don't have iron. Women who become pregnant then need increased amounts of iron because they're not only making, they need to make more red blood cells for the pregnancy. The fetus in utero is also going to make its own red blood cells, and that in utero fetus is going to be dependent on mom's iron store. So mom needs iron for her and the infant. That iron's got to cross over the placenta to get to the infant. So if you look at prenatal vitamins with iron, you can see some fairly higher concentrations of iron in the product. Some of them are going to have as much as 65 milligrams of iron per tablet, where typical over-the-counter multivitamins for women contain between 18 and 28. So you can see a whole lot more iron in the prescription prenatal vitamins. And then if you look at kids, children's chewable, say that 5 times fast, right? Children's chewable. Kids and multivitamins may have 0 iron in it, or it might contain as much as 12. I think some of them might even have 16 milligrams of elemental iron in it. So if you're supplementing your kid with a vitamin, you're worried that they're very picky and they're not getting iron, be sure that you're picking a chewable vitamin that actually has iron in it. Now, if the child has developed iron deficiency anemia, 1 multivitamin with iron in it per day is not going to be enough. Those kids typically need to be treated with much higher amounts of iron, and now the pediatrician, the family practitioner, is aiming for as much as 3 to 6 milligrams per kilo per day of elemental iron. So you can do the math. If you had a 20 kilogram child who is iron deficiency anemic, you can kind of determine how much iron do they need in a day, and then come up, depending on the product, that you're using come up with how much iron you would need to supplement them. All right, so that's a quick thing on iron. The other thing I'll say about iron is some people have a very difficult time absorbing iron. They have profound iron deficiency anemia, or they have profound need for additional iron stores. Iron can be given IV. There's a different product called iron dextran. You could give it IM. I've personally never done that, but I know that that can be fairly painful. Or you can give it IV. Again, individuals who have very marked inability to absorb dietary iron, they're suffering from profound inflammatory bowel disease like Crohn's disease or something like that, may be dependent on intermittent infusions of IV iron. So just be aware that most iron supplementation is done oral, but there's opportunity to do that through the parenteral route as well. Really quickly, sickle cell disease. This is one type of hemolytic anemia, and it's due to aberrations or pathology in the hemoglobin protein. Remember, most adults have two A globulin chains and two B globulin chains. It's considered to be normal hemoglobin. Sickle cell disease, there's a lot of different variations of it, but one of the more common variations is the individual has two A chains and two S chains. And the S chains are aberrant in that they coagulate, and they have a very difficult time holding onto oxygen. The coagulation of the protein leads to the abnormal morphology, or what looks to be like sickling of the red blood cell. This is a genetic disorder. Individuals who are homozygous, who carry the two alleles, are going to have the full-blown disease and symptomatic. The heterozygous individual who only has one of the genes will lack symptoms, but they'll be a carrier, 50% chance of passing that gene on to any of their offspring. This is far more common in African American and Black individuals, much less common in Hispanic, and almost zero prevalence in Caucasians. So I want you to think about this. You've taken a genetics course already. You should be able to answer this question. Can a male and a female who have sickle cell disease have biologic children without the disease? Or maybe another way is, what does it take? What type of male and female need to procreate in order to have offspring with sickle cell disease? You can work that question a number of different ways. All right, so problems with sickle cell anemia is those aberrant cells are more likely to hemolyze. So people with sickle cell anemia have chronic anemia due to hemolysis, but the sickling of those cells make it almost impossible for those cells to be able to move through tight capillary beds, and when they can't get through capillary beds, that results in thromboses, clotting of the vasculature. We're going to talk more about clotting of the vasculature as we move on in this unit here, but you know what I'm talking about when I say clotting and infarcts. You're just plugging up the vasculature with these aberrant sickled cells, which they're no longer pliable. They're no longer able to squeeze through tight blood vessels. And when that happens, when they coagulate and precipitate, you don't get blood flow moving into organs, and that results in numerous infarcts all around the body, particularly in muscle and bone, inner organs. Individuals with sickle cell anemia develop these multitudes of pain crises due to infarcts of bone and muscle, infarcts in the abdominal organs, infarcts in the cerebral vasculature can lead to stroke as well. So a horrible disease, and it's all rooted back to an aberrant hemoglobin molecule. On the opposite end of Anemia is polycythemia when you get too many red blood cells. So the process of erythropoiesis, synthesis of red blood cells, happens in the bone marrow, and it happens in response to hypoxia, low oxygen, particularly if you're at high altitude where there's low oxygen. So what your body's trying to do is compensate and make more red blood cells to increase your O2 carrying capacity. Remember, if you are injecting EPO, you're inducing erythropoiesis, and if you are doing doping, so you've got a normal H&H, nothing wrong with your bone marrow, but you're shooting yourself up with erythropoietin to get some additional red blood cells, that can lead to polycythemia, too much red blood cells, or a higher hematocrit than normal. What do you think is a complication of having too high of a hematocrit? You kind of want to be in the sweet spot. You don't want to be too low. You don't want to be too high. We know if you're too low, you're anemic. But what if you're too high? What happens to your blood? It gets really sludgy, right? And you start putting too much cells in there, the blood gets really, really sludgy. And that can lead to stasis of blood, and stasis of blood can lead to thrombosis all around the body. So polycythemia vera is polycythemia just refers to how too high of a hematocrit. Polycythemia vera is a pathologic condition where you have very excessive production of red blood cells, and individuals now have hematocrit levels greater than 65%. They typically have very characteristic red flushing that you see of the face and digits. They typically are hypertensive, and they have extremely high risk for venous thrombosis, including thrombotic events in the heart and in the brain, leading to heart attack and stroke. Highest incidence of polycythemia vera tends to occur between ages of 40 and 60. Males tend to be a little bit more affected than females. So this is the opposite end of anemia. This is polycythemia. Polycythemia vera is a pretty serious and malignant condition of too much red blood cells, which then leads to excessive viscosity, sludging of blood, and stasis of blood. Let's move into our next topic here. Let's get off the red blood cells, and now let's start talking about platelets and the coagulation proteins. So here we are looking at a blood clot. So this is a blood vessel which has been opened up, and in the middle of that blood vessel now in the lumen you see this dense coagulated clot. And as you can imagine, if you have a big coagulated clot in a blood vessel, that is going to impair your ability to get blood either into tissue or blood out of tissue. So clotting can happen on the arterial end. If it happens on the arterial end, you're not going to get blood into tissue. Clots can happen in veins. So if a clot happens on the venous end, you're not going to be able to get blood out of tissue. Whether the clot is in the artery or in the vein, this is important. Whether the clot's in the artery or in the vein, it can both of those can lead to lack of oxygenation of tissue and hypoxic injury to the tissue. So we have three types of vessels. We've got arteries, veins, and capillaries. The arteries and the veins have smooth muscle in the middle. That smooth muscle is what allows it to relax and open up and increase blood flow, drop the pressure, or constrict and close down, reduce the flow, but increase the pressure. Arteries tend to have much more smooth muscle in it than do the veins. Tend to be a little bit thicker of a vessel. The smooth muscle layer, another term for that, is called the tunica media. The outer region of arteries and veins are connective tissue, the tunica adventitia. But all arteries, veins, and capillaries are lined. The inner lining is what's referred to as the endothelium. In fact, capillaries are nothing more than endothelial cells. Capillaries do not have smooth muscle and all that other connective tissue around it. And we're going to talk about the importance of the endothelium because it is the endothelium which keeps things moving in blood vessels, keeps things from not sticking. Think of the endothelium as a really slippery ice skating ring. And the blood cells are people on ice skates, and they are just gliding over that ice. They're not sticking at all. One of the things that induces blood clotting is damage to the endothelium. So ideally, if we have intact, non-interrupted, non-damaged, normal endothelium, the inner part of those blood vessels should be nice and slippery, and everything keeps moving. The cells keep moving, the plasma keeps moving, the proteins, everything in blood just keeps moving and doesn't stick. So we'll talk more about the importance of this endothelium. We know that blood clots can be bad, right? And you have all seen numbers of different types of blood clots. Blood clots in coronary arteries, such as shown in the upper picture. Blood clots in the lungs, such as an individual might develop a pulmonary embolism. Blood clots in the brain, leading to stroke. Blood clots out in the periphery, something that you might see in sepsis or DIC. Blood clots in the leg, deep venous thrombosis. We'll talk about all these blood clots as we move on here. But we also know that not all blood clots are bad, right? The ability to clot blood can save your life. Cut yourself accidentally, get punched in the nose, develop a bleeding ulcer, right? You don't want these type of injuries to persistently bleed such that you bleed to death. You want to be able to clot damage so that you maintain your blood in the vasculature, right? Look at this last picture here with the hand. Imagine this is a kid he did something. He's running away from police, and he jumps over a chain link fence, sticks his hand up on the fence, and as he tries to get over it, he puts this big gash in his hand, and he starts to bleed. You don't want that individual to bleed to death, right? You want there to be some clot so bleeding stops. Simultaneously, you don't want that clot to get so out of control that he clots off his whole hand. So bleeding and clotting, you got to walk this fine balance in terms of how much clot. You want a clot to occur when it needs to occur, but you don't want it to excessively occur and then start clotting off vital organs. And people can suffer from both ends of the spectrum. People can suffer from excessive bleeding, such as hemophilia, where they don't have the ability to clot blood, or people can suffer from spontaneous clotting, therefore they suffer from excessive amounts of DVT or pulmonary embolism or some other type of clot. So we're going to try to address excessive bleeding and clotting in this next hour or so. So let's move on. I am not going to have you memorize the coagulation cascade, but we are going to talk about the coagulation cascade and why it's important. What is the coagulation cascade? The coagulation cascade is an interaction of platelets and proteins forming an insoluble clot. And we're going to look at some of these important proteins, some of these coagulation factors. Most of these coagulation factors are given a numerical name, such as factor 8, factor 5, factor 2, etc. Remember, we said there's got to be checks and balances. We don't want the coagulation cascade to occur excessively So there's some brakes put on the coagulation factors. The brakes are the red anti-coagulation factors. So endogenously, we have cells that want to clot. Those are the platelets. We have coagulation factors that want to precipitate, coagulation factors. And then we've got some other proteins in blood that try to put a brake on all that and try to either inhibit spontaneous pathologic clotting or put a brake on an active clot such that we don't overclot. Those are referred to as the anticoagulation factors, and we see those in red. Those anticoagulation factors put brakes on certain events within the cascade. And for the cascade to work, it's kind of like a series of reactions. One reaction leads to another, and the eventual outcome of these reactions is to get what's referred to as a fibrin clot, an insoluble clot that's going to plug up the damaged area so we don't bleed to death. Okay, who starts it all out? Platelets start it all out. Platelets are mature cells in blood. Their origin is within bone marrow, and they come from a very big cell referred to as a megakaryoblast. The megakaryoblast is an immature precursor of platelet cells, and that giant megakaryoblast is going to break apart and release numbers and numbers of mature small platelets into blood. So on both upper pictures there show you the up close picture of a really cool looking megakaryoblast. There's a biopsy of bone marrow. Can you see the spongy bone in there? Can you see the trabecular bone and then see all the blood cell production going on? The black arrows are showing you the megakaryoblast. And then on the bottom picture, you can see the platelets, small purple cells on the blood smear. And platelets in and of themselves have no function. When a platelet is released, it doesn't function. It doesn't do any sticking or clotting until it becomes activated. So we have to talk about the activation process. What turns an inactive platelet in blood into an actively clotting platelet? Every other cell that's released into blood, red cells, white cells, they're active. They're able to do their thing. Platelets need to be activated to begin their clotting process. Again, go back to the bone marrow and remember those pluripotent stem cells have the ability to go to a number of different cell lines. So a pluripotent stem cell goes to the myeloid line, and then under the influence of a hormone referred to as TPO, thrombopoietin, those immature cells can develop into megakaryoblast and then eventually into mature platelets released into blood. TPO. So TPO, EPO stimulates red blood cell production. TPO is a natural ligand to stimulate platelet synthesis. So do we have a pharmaceutical product similar to EPO? This is done a little bit different. This is interesting. So we can give individuals erythropoietin, the protein, to get them to stimulate red blood cells. What we do with people to stimulate platelet production is we give them a drug called Promacta. There's the generic term for it, eltrombopag. This is not a protein, but what this drug does is it stimulates the TPO receptor, right? Very interesting concept here. It's a little bit different. So rather than giving the protein, we give a drug that stimulates the protein's receptor. Remember, in diabetes, we have to give insulin. We have to give the protein. Imagine how cool it would be if we had a drug that we can give the person the drug, and the drug stimulated the insulin receptor as opposed to having to give the insulin. Kind of cool to think about that. Maybe one day we'll get to that. But at least with platelets, certain platelet disorders, individuals who are not producing platelets, they can get this drug, and then this drug will stimulate platelet production by stimulating the receptor for TPO. Again, indication, individuals with severe thrombocytopenia. So, anemia, lack of red blood cells, thrombocytopenia, lack of platelets. And again, think about this. So you know what, if you don't have enough red blood cells, you know what the symptoms of anemia are. So now what are going to be the problems? What are going to be the clinical problems of an individual with thrombocytopenia? They don't have platelets. They're going to thus have problems with excessive bleeding, etc. Exactly. Okay, time for a demonstration. Take a piece of paper and give yourself a paper cut. No, don't do that. Let's pretend you did that. Pretend you have a paper cut. Watch what's happening, right? Initially you start to ooze blood, but quickly over a short period of time, that blood is going to start to coagulate and precipitate, and you'll stop bleeding, right? What you are watching in process there is referred to as the primary platelet plug. You are actually watching platelets activate, clump to each other, and start to seal the gap. So now let's talk about what activates these platelets. So anytime you have an injury to a blood vessel, you damage the endothelium. And it is the damage of the endothelium which initiates the platelet activation process. The first thing that's going to happen, you damage a blood vessel, that blood vessel is going to spontaneously constrict. When the blood vessel constricts, right, you're going to get less blood flow in there. So that constriction is going to be one way of preventing excessive bleeding, right? That's a spontaneous event that's going to happen. Damage the endothelium, the blood vessel is going to constrict. When the endothelium is damaged, that's going to expose proteins which are found underneath the endothelium. Remember, the endothelium is a layer of cells of the lumen. It's that very non-sticky layer of cells. If you damage that, underneath it are going to be proteins that are now going to be exposed to blood, and an important protein in there is called von Willebrand factor. When platelets see and get exposed to von Willebrand factor, the first platelets are going to bind to it, and the binding of the platelet to von Willebrand factor is going to result in what's called activation. And activation of the platelet, what we're talking to is the platelet is going to degranulate. The platelet is going to release a number of products inside of it into the bloodstream, which are going to call into play more platelets and activate more platelets. Kind of like white blood cells, right? A white blood cell can degranulate and release inflammatory mediators that call into play more white blood cells. Platelets do a similar thing in that when they degranulate, they're releasing a number of intracellular mediators that begin calling more platelets to the party and activating more platelets. Look at the picture of the up close platelets. You can see that in that blood smear, and you can get a sense that, yeah, those platelets look granular. If you look really up close on them, just like a white blood cell, there's granules in there. What's in those granules and platelets is different than what's in the granules of white blood cells. ADP, thromboxane A2, serotonin, calcium, more von Willebrand factor, ATP. Some of the products that are found inside platelets, very important to the activation process, are two products called ADP and thromboxane A2. When a platelet degranulates and releases ADP and thromboxane A2, it's going to be a stimulus to release more platelets and activate more platelets. And then eventually what's going to happen, all these platelets at the plug are going to start to cross-bind each other, and that cross-binding of all the platelets, cross-binding of these activated platelets is going to initiate and produce that primary platelet plug and try to seal up that gap in the endothelium. So look at the individual who's nicked himself shaving. In each area where he's nicked himself shaving, he's damaged endothelium, and that primary platelet plug process ought to be happening right there. So what happens to this guy if he's deficient in platelets? What happens to this guy if he doesn't have functional von Willebrand factor? What happens to this guy if his platelets can't respond to ADP? He might keep bleeding, right? He might not be able to activate those platelets and get them into that primary platelet plug, and simple things like nick yourself when you're shaving, get a bloody nose, etc., can suddenly start leading to persistent and difficult to control bleeding, either because you don't have enough platelets or your platelets just aren't working. They're non-functional. So here is an example of what the primary platelet plug might look like in terms of a diagram. So between the two endothelial cells, the endothelial cells have the big purple nucleus. Between the two endothelial cells is a gap. Let's suppose that gap is the damage. When you damage the endothelium, now you've exposed those platelets to what we call the subendothelial proteins, one of which is von Willebrand factor. So the first platelets there are going to bind to von Willebrand factor. They have a cell membrane protein. Now the nomenclature here is a little bit weird, but the platelets have a cell membrane protein called GP1B, and that allows them to stick to von Willebrand factor. When they stick to von Willebrand factor, they degranulate and they release products, specifically ADP and thromboxane A2. ADP and thromboxane A2 activate and call into play more platelets. And then as more platelets come in, they start to cross-bind each other. And the platelet doesn't actually bind directly to another platelet. There's an intermediary bridge in there. That intermediary bridge is a protein called fibrinogen. So platelets bind to each other via fibrinogen. Platelets also have another receptor, GP2B3A. Don't you love the nomenclature? That receptor is what allows them to bind fibrinogen. So if you look at this, you see that that platelet plug is fairly complex. It's von Willebrand factor bound to GP1B, and then it's fibrinogen bound to GP2B3A, bound to another platelet. You put this all together, you get the primary platelet plug. Kind of cool, right? So again, some interesting molecular biology. I'm going to show you in a second why I'm showing that to you. And this is why I'm showing it to you, is because we know that a lot of individuals are on antiplatelet drugs. Think of an individual for a second here. Who takes an antiplatelet drug? Individuals who have an increased risk of clotting, right? Individuals with increased risk of heart attack due to coronary artery disease or coronary artery risk factors. Individuals who've had increased risk of stroke or have already had a stroke. Individuals with increased risk of things like DVT or other types of clotting. They might be placed on an antiplatelet drug to try to inhibit the activation of platelets and inhibit the start of this clotting cascade. So what's the most commonly used platelet inhibitory drug? Many middle-aged and elderly adults are started on this drug in terms of prophylaxis. You know the drug, what is it? Aspirin, right? So aspirin, a non-steroidal anti-inflammatory, and other non-steroidal anti-inflammatory drugs like ibuprofen inhibit platelet function. They inhibit platelet function because they inhibit the platelet's ability to synthesize thromboxane A2. Thromboxane A2, critical in the primary platelet plug. If you don't have thromboxane A2, you inhibit the platelet process. What's another important factor in the primary platelet plug? Another important factor is ADP. So you've seen people on Plavix and Effient and Brilinta, right? Another type of anti-platelet drug. Again, individuals with high risk or known coronary artery disease, cerebral vascular disease, they may be put on something like Plavix or Brilinta. Maybe they've had coronary artery stenting or something, right? And they go on antiplatelet. Well, why is that drug antiplatelet? That drug's antiplatelet is because it's inhibiting the action of ADP. That receptor called P2Y ADP, that's a receptor on the platelet that is activated by ADP. Take that away, platelet can't activate. And then you get some really weirder type drugs that you're never going to see in a retail pharmacy, you're never going to see in ambulatory medicine, but for those of you that work particularly in a cardiac cath lab, particularly when angioplasties are being done, you may see an individual get an anti-platelet drug, an IV antiplatelet drug like ReoPro or Integrelin, and those are drugs which are proteins that are directly inhibitory to that GP3B2A. And when you inhibit that, you completely block the platelet's ability to cross spine, and therefore you can't clot. And that would be a useful thing, right, for somebody who's having acute MI and going for acute angioplasty. It'd be a good thing to not clot off the stent or not add further platelet clotting into the stenotic area. So very, very potent, very rapid acting effective drugs like ReoPro, which is a monoclonal antibody against that receptor, or Integrelin, which is a protein, which is actually something that you see in rattlesnake venom. Any of you guys ever bit by a rattlesnake? I hope not. Any of you guys ever seen a victim of a rattlesnake bite? What happens to people who are bit by rattlesnakes? One of the things that can happen is they bleed, and they bleed because their platelets aren't functional, and that's due to a protein in the snake venom. Now that protein in the snake venom has been used in this drug Integrelin, used pharmaceutically to help certain individuals in the cardiac cath lab, particularly with angioplasty. So again, some pharmacology. If you understand the primary platelet plug, now you start to understand why a lot of these drugs have different mechanisms of actions in terms of inhibiting platelets and why inhibiting platelets may be useful. And we'll talk more about this again when we get in the cardiovascular unit. Okay, when should you suspect a person has a platelet problem? Either they don't have enough platelets or the platelets that they have can't activate. They're dysfunctional. What is the characteristic rash that you see in an individual with a platelet problem? You can see this rash on mucosal surfaces, or you can see this rash on skin. What's that rash called? That's right there. Petechiae, right? Have you all seen a petechiae rash? Pinpoint red rash that doesn't blanch. You see that all around the body. Very common on the face. Very common on mucous membranes. So petechiae is one thing you're going to see. And what else do you see in people with platelet problems? They have excessive bleeding, right? And they tend to have excessive bleeding from mucosal surfaces. So bloody noses, which won't stop. Menorrhagia, excessive menstruation. GI blood, rectal bleeding, blood in the toilet, right? So petechiae and mucosal bleeding. You see that, you got to suspect some type of platelet problem. So one platelet problem could be that the individual just doesn't have enough platelets. Their platelet counts are low. So normal platelet counts are 100,000 to 450,000. And then we can start dropping platelet numbers. And the lower you get, the greater is the risk for bleeding which doesn't stop, and the greater is the risk for spontaneous life-threatening bleeding. Most people are going to be okay down to 30 down to 50, even 30,000. Once you start getting under 30,000, now you start seeing an increased risk for significant bleeding, particularly with minor trauma. Under 10,000 now starts to become a risk for internal bleeding, and definitely under 5,000, much higher risk for spontaneous internal bleeding, including into the GI tract or into the brain. So we want to be sure that people with thrombocytopenia, we want to be able to get their platelet counts up. We don't need to get them up over 100,000, but if we can get them up to 30, maybe that's enough to protect them from spontaneous internal bleeding. So why might people have thrombocytopenia, lack of platelets? Their bone marrow has failed for a lot of different reasons. Drugs can cause the bone marrow to fail, viral infections, infiltrations with cancer, radiate the bone, chemotherapy, sepsis, B12 deficiency can also affect bone marrow failure. So bone marrow failure, that you're not making the platelets, or you can destroy platelets. In the same way that you can destroy platelets, in the same way that you can destroy red blood cells through the process called hemolysis, you can also destroy platelets. You can have platelets be torn apart inside the body, and there are multiple reasons why that might happen. We're going to talk about a couple of them, particularly one thing called ITP, autoimmune thrombocytopenia. So just like an individual can have autoimmune hemolytic anemia, you are generating autoantibodies against your red blood cells. ITP is the generation of autoantibodies against your own platelets. You destroy the platelets, and now your counts drop, and you develop severe thrombocytopenia. HIV infections, lupus, DIC, viper venom, being bit by rattlesnake and other type of venomous creatures, also can lead to destruction of platelets. Here's ITP. So you have an individual with mucosal bleeding, mucosal and skin petechiae. You get a platelet count and you find out that they're thrombocytopenic. Well, one of the causes of that is autoimmune by nature. Individuals are making autoantibodies, usually IgG antibodies, against that one cell membrane platelet receptor. Remember that GP2B3A is an important receptor to help the platelet cross-bind the fibrinogen. Now these autoantibodies are attacking that protein on the platelet, leading to destruction of the platelets. This has an incidence about 1 in 10,000. Children far more affected than adults. Females far more affected than males. If it lasts for less than 6 months, call it acute. Lasts for greater than 6 months, it's chronic. Most kids have acute ITP. With treatment, it tends to resolve. Most adults have chronic ATP, and that may be a long-term problem that may need to deal with. So this IgG attacks the platelets. Platelets that are covered in this IgG then are broken apart and destroyed in the spleen or the liver. And very often these individuals will have markedly diminished platelet counts, often under 5,000. If you were to do a bone marrow biopsy, their bone marrow usually looks okay. The problem is not destruction in the bone marrow, the problem is destruction out in the periphery. So one way to differentiate ITP versus leukemia or other types of bone marrow failures, do a bone marrow biopsy. You see normal appearing bone marrow, you see those healthy megakaryocytes in the bone marrow. You see, you can make that diagnosis of ITP. The blood smear, see the blood smear with the black arrow there? That's what's called that's a giant superplatelet. That's something that you see in ITP. The bone marrow is trying to keep up, so it starts releasing some of the immature cells. So sometimes you can see some of those immature, larger megakaryocytes released in the plasma, into blood. That might be a finding that you see in ITP. But more important, what I want you to remember about ITP is that this is an autoimmune process. Can you treat ITP? Yes, you can. Most kids are going to respond and remit within a few months, but again, most adults will respond, but it might take them longer. Chronic ITP, where it doesn't respond and it stays persistent, most of the time you see that in adults. And people who die due to ITP, people who have some lethal bleeding events, such as a brain hemorrhage or something like that, more commonly you see that in adults than you see that in kids. One thing that you do want to do is differentiate ITP from leukemia. That can be done with a bone marrow biopsy. Talk about leukemia in a minute or two here. A mom who develops ITP during pregnancy, that's not good. Not only is she at risk of bleeding, but those autoantibodies can cross the placenta and start to adversely affect the infant on the other side of the placenta. So that's something that's also screened for in pregnancy, are platelet counts. Okay, can you treat ITP? There's a lot of different ways to treat ITP. You can see them all listed here. Remember, the glucocorticoid steroids suppress the immune system. So drugs like prednisone, prednisolone could be treated. Rogam and immunoglobulin can be given to counter the autoantibody of ITP. You can do an IV infusion of gamma globulin. Really interesting. So the problem with ITP is gamma globulin attacking the platelet, and then we treat that with a different type of gamma globulin. So IV gamma globulin, and a person with ITP can actually inhibit the phagocytosis of those platelets. And usually the quickest way that you can get platelet counts up in an individual with ITP is to give them IV gamma globulin. Why might giving them somebody else's platelets, why might giving them a platelet transfusion may only temporarily work for a very short period of time? Yeah, because the autoimmune process may attack the transplanted platelets. And again, you might be able to give them some platelets and for a very brief period of time control bleeding, but those platelets will eventually get broken apart. So management, at least what I see, the big management for ITP now is to give them this IV gamma globulin, and that IV gamma globulin inhibits phagocytosis. Another important thing that we can do is use the glucocorticoid steroid and inhibit the autoimmune reaction as well. Have you guys ever given synthetic gamma globulin? Synthetic gamma globulin is actually pooled IgG from multiple donors. There are numbers of different types of pharmaceutical gamma globulin. Most of the gamma globulin is IgG content. There are a lot of different indications for giving somebody gamma globulin. So if they have an autoimmune disorder such as autoimmune hemolytic anemia, ITP, and you want to stop the destruction of the blood cell, this might be useful. Individuals who have IgG deficiency, individuals with life-threatening or chronic infections, you might be able to give IgG. A lot of different reasons why you give IgG. Those of you working in internal medicine floors, particularly if you're dealing with HIV patients and stuff like that, you probably see gamma globulin given. I'm throwing this in this unit right now to show you that infusion of gamma globulin can be very useful for some of these individuals with diseases like autoimmune hemolytic anemia or autoimmune ITP. HUS, a very interesting disease, which is usually a foodborne disease. So hemolytic uremic syndrome is being exposed to a certain type of E. coli, a specific strain called O157H7. That type of E. coli elaborates protein toxins that lead to the destruction of both red blood cells, the hemolytic component, and platelets. So red blood cells drop, platelets drop, and then these proteins are also toxic to the kidney. That's the uremic portion of it. So these individuals now are destroying red blood cells, destroying platelets, and going into acute renal failure. And a lot of different things can lead to exposures of this certain type of E. coli. This is a type of E. coli that you see in animal feces. So food products which have been contaminated with animal feces, particularly if those food products have not been properly cooked, can result in the ingestion of these bacteria and these toxins, and then you get this horrible disease called HUS. And I think probably all of you at one point have heard of an outbreak of HUS due to consumption of either raw or other contaminated hamburger. The first outbreak of HUS in the United States due to a fast food restaurant happened in the west coast of the US back in the early 1980s, and that was contaminated hamburger at Jack in the Box restaurants. I have never ate at a Jack in the Box restaurant, and it's not because they were the first ones that had the outbreak of HUS. It's because that freaking clown is so creepy. Man, that clown is just so creepy. I'm sorry. I don't care if that's the greatest fast food place in the world. I'm never going to eat at a Jack in the Box because I can't stand the mascot. If you're from Milwaukee, you probably remember back in 2000 there was a huge outbreak of HUS, and that was traced back to a Sizzler restaurant on the south side of Milwaukee, in the region of 6th and Layton, right by the airport. And it was not due to contaminated meat, it was due to watermelon. It was contaminated watermelon on the salad bar that led to a number of individuals developing HUS. I think in total there were 5, maybe 6 pediatric deaths that summer due to that. And then petting zoos. You've heard of HUS outbreaks or kids getting HUS due to petting zoos. What's going on there? Are these children eating the pet, right? Are these children like little zombie children eating the live animals? No. What's happening here is, as you see in the picture, they're petting the animal. On that animal hide is going to be the E. coli bug, that animal rolling in feces in the hay or whatever, so you can have that bug on the kid, and then the kid goes and eats lunch, eats their packed peanut butter jelly sandwich, whatever is sent for the field trip, but they didn't do a good job washing their hands, and now they're getting exposed to the organism. So you got to be careful. Got to be careful with food poisoning. I'm going to talk a little bit more about food poisoning in the GI unit, but I wanted to bring this up really briefly here. HUS, you see an individual with hemolysis, thrombocytopenia, and going into renal failure. That's HUS, and a lot of times that is traced back to that specific E. coli, and that E. coli and its toxin can usually be assayed to confirm the diagnosis of HUS in the individual. Petechiae and mucosal bleeding. Think platelets. You get a platelet count, you get a CBC, but the platelets are normal in count, right? So now you've got an individual with petechiae, mucosal bleeding won't stop, but you got a platelet count of 250,000. You say, geez, the platelet count's normal. Why are they bleeding? Well, it might be that their platelets aren't working. So really quickly, there's a lot of different things in terms of why platelets may not work. What do you think is the most common reason why individuals' platelets don't work? They're not functional. It's drugs. Think of all the people that are on aspirin, Plavix, and all these antiplatelet drugs. You put somebody on an antiplatelet drug and they got normal platelets, but they don't work, right? So drug-induced platelet dysfunction is common. And then there's a number of other reasons why platelets don't work. Von Willebrand's disease, remember von Willebrand factor, that critical subendothelial protein that initiates the clotting process, initiates the primary platelet plug. There are individuals who genetically lack von Willebrand's disease. And there's a whole severity in terms of complete lack versus partial lack or partial function. So there's severe von Willebrand's disease, and then there's not so bad von Willebrand's disease. Well, that's a hereditary disorder, and you can see there's other hereditary disorders as well. Renal failure can lead to inactivation of platelets. Liver failure can lead to inactivation of platelets. So a lot of things can make your platelets not work. You see somebody with petechiae and mucosal bleeding, you want to get a platelet count, but you better be asking about what drugs they're on, because some drugs are going to be directly inhibitory to the platelet, but remember, a lot of drugs cause bone marrow dysfunction. That is a characteristic of certain anticonvulsant drugs and other types of drugs. Even some antibiotics can inhibit bone marrow function, can lead to a lack of production of platelets. So be careful with drug therapy. Better living through chemistry, but a lot of bad stuff can happen as a result of drugs. Anemia, lack of red blood cells. Thrombocytopenia, lack of platelets. Pancytopenia, loss of all blood cell lines. Where have you heard that prefix pan in this course? Think back a couple units. Remember we talked about pan hypopituitarism, complete failure of the pituitary, where numerous hormones are low. Pancytopenia, we're using that prefix again, pancytopenia, loss of all blood cell lines. So now you've got total suppression of the bone marrow rather than just suppression of one cell line. Total suppression of bone marrow can happen for numbers of different reasons. It could be genetic, it could be an inherited disorder. It could be due to infiltration of the bone marrow by cancer, metastatic cancers, including cancers which arise in the bone marrow, leukemia. Aplastic anemia, I want you to read really quickly what aplastic anemia is, a hereditary disorder that leads to bone marrow failure. Overwhelming viral infections, overwhelming bacterial infections, overwhelming exposure to radiation or toxins. And then remember, like I said, chemotherapy can destroy bone marrow. Numbers of other types of drugs can also destroy bone marrow. If you look at table 28.4 there, you can see a list of a number of different drugs that destroy bone marrow. You don't need to memorize that for this course, but you should be aware that if you have a patient who suddenly starts showing drop in all the blood cell lines, better go through a medication history and see what they're taking, as that might be a drug-induced effect. All right, pancytopenia. Quickly here, we're going to talk about leukemia, a cancer of blood cells. A hallmark finding of leukemia are the primitive, immature cells which have become malignant, and they're usually referred to as the blast cell. The blast cell can be of either lymphoid or myeloid line. Remember, the stem cell in bone marrow, one of the first differentiations it's got to make is either become lymphocytic or myelocytic, and then it can go through a number of immature stages before it gets to the mature cell. So all along the immature stages, one of those lines, one of those cells can suddenly stop obeying the rules of growth and reproduction and differentiation. And remember what happens when a cell decides to kind of go rogue and start growing and replicating and abnormally, it's one of the root causes of malignancy, right? So leukemia is a primary cancer of which begins in bone marrow, and it begins in one of these cell lines. And the toxic, or not the toxic, the cell that becomes malignant, that specific cell is usually referred to as a blast cell. So we can get lymphoid blast and myeloid blast. Some of the immature cells, sometimes you can find immature cells in peripheral blood. So that last line that it says, usually occupy less than 5% of marrow and never found in peripheral blood. We're talking about certain types of immature cells. That my text in there is probably grammatically wrong. You should not be finding malignant blast cells in bone marrow. You should only be finding small amounts of immature bone marrow cells in peripheral blood. And when you start finding high amounts of immature cells in peripheral blood, and those cells are characterized as being blast cells, that's leukemia, okay? And those blast cells are going to be differentiated back as lymphoid or myeloid. Here's another graphic that can show you the different types of immature cells which arise from those pluripotent stem cells, and each one of those different lines, the lymphoid line and the myeloid line, can get rogue, start growing rapidly and uncontrolled, leading to scores and scores of these blast cells overtaking bone marrow and starting to be released into blood, and now you have a state of leukemia. So there's a couple figures and tables here that I want you to look at with respect to leukemia. Again, just differentiating for you that uncontrolled proliferation of malignant bone marrow cells. Bimodal distribution, you tend to see leukemia in children and in elderly adults. The association with oncogenes, there are a number of oncogenes now that are associated with certain types of lymphocytic leukemias and myelocytic leukemias. You can take a look at some of the epidemiology in terms of cases and deaths and individuals who survive. Maybe the most important thing that I want you to take a look at are what are some of the clinical manifestations of leukemias. Leukemias can lead to pancytopenia. So an individual with leukemia can present with anemia, thrombocytopenia, and recurrent or overwhelming infection due to lack of white blood cells. These white blood cells, which are malignant and overcoming the bone marrow and getting into peripheral circulation, are not functional. They're malignant cells which are not fighting infection. And when your white blood cells, when you don't have normal white blood cells and you got all these immature malignant blast cells, suddenly you can't fight infection. And the more these cells start to infiltrate tissue, the more can be the clinical symptoms. Infiltration of leukemic cells into bone can lead to bone pain, joint swelling, joint pain. So take a look at that. Take a look at clinical manifestations and be aware, individuals with pancytopenia, one thing that you better be highly concerned about is the potential for leukemia, particularly the youngers and the younger children and the elderly because of that bimodal distribution. Let's see, what do we got going on here? On the left side, we see a normal blood smear, normal distribution of mature blood cells and plasma. On the lower left, normal distribution of immature and maturing blood cells and bone marrow. And now on the right, we see some examples of leukemia. Leukemia in blood. So you see the blood being overtaken by those malignant blast cells. You don't see any normal white blood cells in there, right? You see a bunch of abnormal blast cells. And then look at the bone marrow. See how the bone marrow now starts to show this accumulation and overtake by those malignant blast cells as well. And as you see those malignant blast cells overtaking the bone marrow, now you can start to understand why the individual develops pancytopenia. You're just being replaced. Cancerous cells are replacing the healthy precursors to red blood cells and platelets and the white blood cells, and now this individual becomes pancytopenic. So there's some very pretty, very interesting pictures there of normal blood and bone marrow and then infiltrated blood and bone marrow with some leukemic cells. Okay, quick review on the platelets. When do you suspect a platelet disorder? When the individual is showing petechiae or persistent bleeding from mucosal surfaces, bleeding that doesn't stop after a simple procedure such as a dental procedure or other procedures like tonsillectomy, circumcision, right? Individual who keeps bleeding from a mucosal surface, got to consider a platelet disorder. Look at platelet counts, see if they're thrombocytopenic. If the platelet counts are normal, think about what platelet function may be going on, and always consider the possibility of an antiplatelet drug, either a drug given to them that has its effect on platelets, like a non-steroidal, or a drug which may be having an adverse effect on bone marrow. Okay, folks, hang in there. We're getting close to the end. This is the last of the topics, and we're going to talk about thromboses, right? So we're talking about platelet disorders, and particularly platelet disorders leading to problematic bleeding. Now let's get back to problematic clotting. And we're going to cover coronary artery disease and clots in coronary arteries in more detail in the cardiac unit. We're going to cover pulmonary embolism, clots in the lungs in more detail in the pulmonary unit. We're going to talk about CVAs and stroke clots in the cerebral vasculature, more in the neuro unit. So we're going to use this just kind of as a foundation to talk about clotting, and we're going to use DVT, deep venous thrombosis, as our primary clinical syndrome of abnormal clotting. So a little bit right now and a whole lot more as we get into more of this course with respect to clotting. Coagulation cascade again. Factors in black, coagulation factors promoting the clot. Factors in red, anticoagulation factors trying to limit the clot. It's all about checks and balances. As soon as you start activating the clotting process, you also begin activating the anticoagulation process. You don't want the clot to get out of hand. The goal is to form this insoluble fibrin clot, which is going to patch up the bleeding area that's been damaged. Now remember, platelets start the reaction. So the clotting cascade begins with platelet activation. Eventually those platelets are going to interact with the clotting factors. Kind of cool and interesting, all these different reactions that are occurring between these different proteins. A lot of them are actually occurring on the cell membrane of the platelet. Kind of cool. So platelets and these coagulation factors get together to lead to this insoluble clot. The clotting cascade, so platelet activation mediated by platelets and platelet activation factors, clotting cascade mediated by these serum proteins, which all have named by some Roman numeral. The reactions don't happen in order, so it's not numerically arranged, so don't try to look for any kind of numerical sense on this. But again, one factor activation leads to the next. These protein factors typically are free floating in plasma and exist in inactive states. And once platelets start to activate on the cell membrane of those platelets, now we start seeing further activation of the protein factors. There's actually three pathways in the clotting cascade. There's an intrinsic cascade, and then there's an extrinsic cascade. The intrinsic and the extrinsic cascade all lead to factor 10A. Roman numeral 10 is X, so 10A. What's the difference between X and XA? X, factor 10, is inactive. XA, factor 10A, has been activated. So proteins in the intrinsic path and proteins in the extrinsic path are trying to get to 10A. And then once you get to 10A and you go down to your fibrin clot, that's the common pathway. So you've got intrinsic, extrinsic, and common, and you've got different protein factors involved in each of the pathways. Don't memorize the pathway. If you're working in hematology and you're working with hematologists and you're doing a lot of this, well then maybe having that additional knowledge of terms of how the pathway goes is maybe important, but I want you to be able to look at key actions in the pathway, okay? I'm going to show this to you in a minute or two here. I have no expectation that you should be able to draw out and memorize this pathway. But I do want you to understand that it's the interaction of platelets with these coagulation factors that's eventually going to lead to that insoluble fibrin clot that's going to plug up the damaged vessel. Checks and balances. When we start to coagulate, we also start to anticoagulate. So TFPI, antithrombin, protein C, and protein S are all anticoagulation factors, putting the brake on key areas in the clotting cascade, trying to inhibit spontaneous clotting and maybe more importantly, trying to inhibit clotting from getting out of hand. And you can see that those anticoagulation factors have some specific regions where they work. So antithrombin 3 works at factors 10 and 2, where protein C works at factors 5 and 8. All right? So just like the coagulation factors only interact with specific factors, right? The anticoagulation factors also only interact with certain factors. Okay, now I'm going to give you some diseases. I'm going to want you to think about this. Some of these diseases are going to lead to excessive bleeding, meaning the patient is anticoagulated, and some of these diseases are going to lead to excessive clotting. All of these diseases, with the exception of vitamin K, are hereditary diseases. I skipped over vitamin K, didn't I? Okay, remember that I said that the coagulation factors exist in either an active or an inactive state. What is it that makes a factor active? There's a couple of things, but one important thing that makes some of the factors activated is the action of vitamin K. Factors 2, 7, 9, and 10, 2, 7, 9, and 10 are vitamin K dependent factors, meaning that you need vitamin K's action on those factors to become active, okay? All right, now that I've said that to you, you can answer the questions here. Take each one of these disorders and push it to either the left or the right. Is the person going to have excessive risk for excessive bleeding, meaning they're anticoagulated, or are they going to have a risk of excessive clotting, meaning they're going to have spontaneous clotting and increased risk of pathologic clotting? You should be able to do this if you think about it. You may need to look at the coagulation cascade to do this. You may need to go back and review what I said about platelets to do this as well. But if you can do this, you're kind of getting it. You're starting to understand what's going on here. Virchow's triad. Virchow's triad states when these three things occur, you got to increase risk of forming a clot or a thrombus. So remember, thrombus begins, endothelial injury is important. When you damage the endothelium, you expose platelets to von Willebrand factor. That exposure to von Willebrand factor begins the activation process of platelets. Abnormal blood flow, particularly blood which is stagnant. Stagnant blood means that blood is just kind of sitting there and it's not moving. That increases the risk of hypercoagulation. Stagnant blood, hyperviscous blood. What's the disorder where an individual has very hyperviscous blood? You remembered polycythemia vera, right? Disorders like that. Stagnant blood, sitting on an airplane for 8 hours with your legs crossed, sitting in class with your legs crossed, right? Why is blood stagnating? Because you're not moving your lower extremities, you're not pumping blood out of your legs, and then you're inhibiting venous flow by crossing your legs, right? So the stagnation of blood, and then hypercoagulability. Hypercoagulability refers to either genetic or acquired risk factors that make it more likely that you'll clot. And we're going to look at this in a second here, okay? So this is Virchow's triad. The endothelium is damaged, your blood is stagnant or hyperviscous, or you have some other factor which puts you at increased risk of hypercoagulability, such as a deficiency of protein C. Put these three together, you got Virchow's triad. Increased risk of thrombus, pathologic blood clot. Here's some examples of pathologic blood clotting. Remember, blood clotting can happen on arterial vessels. It can happen in veins, so arteries and veins. Whether the clot happened in an artery or whether the clot happened in the vein, you're going to get hypoxic-induced injury to the tissue. These are some examples of some arterial clots. Arterial clots to the lower extremity. See the blue foot there, right? The deoxygenated foot. Somewhere in the vasculature of that leg is a clot. Middle picture there shows a clot in the renal artery. What can happen if suddenly there's no perfusion to the kidney due to a blood clot? There's a blood clot in the carotid artery, can lead to stroke. There's some mesenteric ischemia. You can see some region of the bowel looks pink and healthy, but other region of the bowel looks black and necrotic in the way that that foot looks black and necrotic, right? So here's some examples of arterial clotting. But again, remember, venous clotting can also lead to tissue hypoxia. Thrombus, where the clot formed. Embolism, where the clot went. So if the clot formed in the leg, and then part of that clot broke off and traveled and ended up in the heart or ended up in the lung, that's the embolism, okay? So where the clot forms, thrombus, part of the thrombus breaks off, goes to another region of the body, and embolism. Clot forms in the left atrium, thrombus. Part of it breaks off, goes up the aorta and up into the brain, embolism. Again, arterial clots and venous clots. The clinical presentation of an arterial and a venous clot. Think about, what might you take an extremity and then think to yourself, okay, what would it look like if no blood flow is going into that extremity due to an arterial clot, or what might that look like if I can't get blood out of the extremity because of a venous clot? And this slide here kind of summarizes for you a little bit of difference between an arterial clot versus a venous clot. They're both going to be painful. They're both going to result in numbness and tingling. They both have the potential to lead to hypoxic damage of the organ. Arterial clots tend to be pale and cold due to lack of blood supply. Venous clots tend to be red and warm due to the inability to get blood out of the tissue. DVTs, deep venous thrombosis. Thrombosis meaning that's where the clot's starting. Vein meaning the clot's starting in the vein. Deep meaning it's occurring in the deeper non-superficial veins. So we can say lower extremity DVT, a thrombus which is occurring in one of the deep veins of the leg. A lot of these clots happen around valves. Remember, in the lower extremities, we have this kind of like stair system of valves inside the lumen that just kind of helps prevent backflow, and it helps us kind of keep moving blood proximally and up the leg and into the iliac veins and into the vena cava and back to the heart, right? But around these valves is where we start to see stagnant and turbulent blood flow. So a lot of these DVTs tend to occur around the region of the the valves because of how blood flow becomes naturally stagnant and turbulent rather than nice free-flowing blood. In the region of those veins now we start to see some stagnation and turbulence, and that's part of Virchow's triad, right? Abnormal blood flow. So you can see the clot developing there in the vein in the graphic, and then you can see part of it breaking off and becoming the embolism. Take a look at the picture in the upper left and decide for yourself which side has the lower extremity DVT. I'm quite certain that everybody in this course, based on your experience in nursing already, have seen individuals with lower extremity DVTs. All right, symptoms of a lower extremity DVT. Typically unilateral pain and swelling, warmth, discoloration, limited mobility, palpable tenderness very often in the calf muscle, pain with foot flexion, and discrepancy in circumference measurements, right? That's important. Trying to differentiate a DVT, somebody comes in with unilateral leg pain in the early stages of it, it may not look warm and swollen, but you take out your tape measure and you take some measurements around the thigh and below the knee, and you find out, ooh, hey, there's a couple centimeters of discrepancy here when I measure it. I may not have been able to differentiate that just by looking at it, but when I measure it, I see that discrepancy, right? So unilateral pain and swelling in a leg, that's one of the first things you got to be concerned of, is a DVT, thrombosis in a deep vein. Now, people got a lot of superficial veins. You know, you can look at your own legs and see if you've got superficial veins or not. Those superficial veins can clot and lead to pain. The thing with the superficial veins clots is the superficial veins, the varicose veins, if they get thrombus in it, they almost never embolize. It's thrombus in the deep veins that are worrisome because that can embolize. Leave the leg, get into the iliac vein, get into the IVC, get back to the right heart, get clot in the right heart, and then remember the right heart pumps to the lungs. So lower extremity DVTs are typically the source of a pulmonary embolism. We're going to cover pulmonary embolism in more detail in one of the pulmonary units. All right, easy question for you. Picture on the right, which of those, on which side is the DVT? That one's an easy one, right? and more for you. Which side is the DVT? You have a person with pain, swelling, warmth, discoloration, limited mobility of one leg versus the other. The confirmatory diagnostic modality is an ultrasound, right? Ultrasound with Doppler flow. Go on YouTube and look up ultrasound of a DVT. There's a lot of cool videos that you can look at. If you know, I'm sure a lot of you have been able to see bedside ultrasounds being performed on individuals with DVT. If you haven't had that opportunity, you know, make sure that you try to get that and try to see someone with a DVT and have them perform see the ultrasound being performed while you're there. There's a couple static pictures of a clot on ultrasound. So on the left picture, you've got the vein to the left and the artery to the right. The artery looks nice and open. You look at the vein and you see this big precipitated, coagulated ball in the middle of there. That's a DVT if that were in the iliac vein. That's a cross section. And then if you look at a longitudinal, in the next picture, you see the artery on top wide open, and then see that big coagulated mess in the vein. So there you go. There's nice static ultrasound pictures of clot in an iliac vein. But go on YouTube and look at some stuff. Try to look at it, you know, when it's happening at your institution. They are really cool pictures to look at. All right, hypercoagulation. What do I mean by hypercoagulation? It means that you have an increased risk for clotting. So there's genetic disorders that put you in increased risk for clotting. If you are genetically deficient in an anticoagulation factor, such as antithrombin 3 or protein C, you have an increased risk of clotting. If you have elevated levels of coagulation factors, you're going to have an increased risk of clotting. If you have excessive activity of a dysfunctional coagulation factor, and a very important one there is called factor V Leiden. Factor V Leiden is a factor V that can spontaneously activate, lead to clotting. Those are some of the more common genetic things that make you at increased risk for clotting. Now there's a number of acquired risks for clotting, meaning it's not necessarily genetic, but it's something that you have. So a big one, if you've already had one blood clot, you have an increased risk of others. Immobility, right? Sitting with your legs crossed for a long period of time. Leg in a cast for a long period of time. One of the really crazy cases that I remember seeing in my lifetime was a 12-year-old kid who came in the emergency department with a big DVT in his leg. You usually don't think of healthy kids as having DVTs. This kid was sitting Indian style in front of a video game for hours. Now, it might be politically incorrect to use that term, Indian style, but you know what I mean when I say that, right? He's kind of sitting on his butt, on his legs, with both of his legs crossed over each other, and he's sitting like that for a very prolonged period of time, playing a video game. He gets up, he can't move his leg is swollen. Kid had a DVT. Crazy to think of that, right? You usually hear that more commonly. This is why they want you to get up and move around when you're on an airplane, take breaks when you're driving a car, sitting in a classroom, right? Get up, move around, because it's the contraction of skeletal muscle in your legs that's helping you push blood and move blood so it doesn't get stagnant. So immobility. As nurses, you know that people are in bed for a long period of time. You know, what do you do for people who are in bed for a long period of time, post-op, or even just coming in for a day surgery, right? What are you doing to help keep blood moving in their lower extremities, right? Certain malignancies increase the risk of DVT, particularly malignancies of the GI tract and ovarian cancers. Estrogens increase the risk of DVT. So people who are taking certain types of synthetic estrogens, either in oral contraceptive tablets or estrogen replacement. Got to be careful with oral contraceptive tablets, right? You guys know that, particularly if you are, you're going to be nurse practitioners. I know a lot of you are going to work in family practice, and you're probably going to be working in women's health and discussing and prescribing and maintaining individuals on hormonal contraception. Boy, you better be careful with the hormonal contraceptives that contain estrogen, because that is increasing risk of DVT. Obesity, smoking, pregnancy. Let's come up with 2 reasons why pregnancy increases the risk of DVT. You got them? The obvious one is what? The big uterus and the baby inside the uterus. So collapsing and compressing pelvic veins, particularly iliac veins, and potentially even the IVC, that can lead to venous stasis in the lower extremities. What's the hormonal thing about pregnancy that increases the risk? What hormone is shooting up and going through the roof during pregnancy? Estrogen, right? Yeah, estrogens. Estrogen increases the risk of thrombosis. Indwelling catheters, artificial heart valves, some other disorders there. What I want you to be able to recall, and I'm going to test you on this on both the quiz and the exam, is everything in black. So everything in black, all those acquired risk factors. I think it's imperative for you to understand what are those acquired risk factors for increased risk of thrombosis. Box 29.9 also has these listed as well. So very important. Anticoagulant drugs. I know a lot of people like to use this term blood thinner. Oh, it pains me to hear that. As an individual who's a pharmacologist and loves to talk about mechanism and loves to categorize drugs by mechanism, I like drugs being referred to as being antiplatelet, anticoagulant, or fibrolytic, not blood thinner. Do me a favor, please don't say blood thinner. Aspirin is an antiplatelet drug. Plavix and Brilinta are antiplatelet drugs because they're antagonizing the platelets. We have a lot of drugs that are antagonizing the coagulation factors. I like to call those anticoagulant drugs. So Coumadin antagonizes vitamin K. Xarelto antagonizes factor 10. Pradaxa antagonizes factor 2. Those are antagonist drugs. Heparin, low molecular weight heparin like Lovenox, Fondaparinux, those are enhancing the action of an anticoagulant protein, specifically antithrombin 3. So they're enhancing action, therefore they're agonists. I'd love to sit for another hour and talk about anticoagulant drugs with you, but we're going to leave that for pharmacology. What are anticoagulant drugs doing? Well, just like an antiplatelet drug is trying to make the platelet dysfunctional, the anticoagulant drug is either trying to make the coagulation factor dysfunctional or trying to enhance the action of the anticoagulant. So 2 of the most commonly used drugs, Coumadin, antagonizing vitamin K, therefore you do not get activation of factors 2, 7, 9, and 10. Heparin, increasing the action of antithrombin 3, so you get more break by antithrombin 3. The newest drugs on the market are the oral drugs like Xarelto, Eliquis, Pradaxa, and these drugs are a little bit more specific. What they do is they directly bind to either factor 10A and inactivate it, or directly bind to factor 2A and inactivate it. And these drugs are getting more and more popular and used more and more commonly. I'm sure all of you who are working with high-risk DVT and high-risk thrombotic patients are seeing the use of these newer drugs like Xarelto and Pradaxa. DIC. Last thing here is DIC, and the only thing I'm going to say about DIC is this is bad. This is life-threatening. It's a condition where there is both excessive coagulation and excessive bleeding happening simultaneously. Coagulation factors are being activated, leading to thrombosis. Platelets and coagulation factors are being consumed, leading to bleeding. This is a horrible disease, something that you see with severe infections. DIC is usually the result of some underlying disease: sepsis, viral infections, severe trauma, severe burn, a complication of obstetrics, such as an in utero fetal spontaneous death, or abortion gone wrong, placental abruption. Sometimes you see this from envenomation of poisonous creatures, like rattlesnakes. There's a lot about DIC in the textbook, 5 pages on it. Other than what I want you to know about DIC, it's like this simultaneous thrombosis and bleeding going on, and its underlying cause can be very difficult to treat. You got to get at the underlying cause. If you can't get at the underlying cause and reverse the underlying cause, this almost always results in a fatality. Very nasty. I'm sure some of you who have seen this can just go on about horror stories about really extremely ill patients that you've seen in DIC. All right, I'll leave DIC alone. You can read a little bit more about DIC if you're interested in it. All right, folks, there we go. Just under 2 hours and 20 minutes. A whole lot of stuff in there about blood and blood cells. I think some really, really interesting pathologies we covered. Again, we skimmed through some stuff. We got into some detail on others. There's a lot of things about blood that we haven't talked about. Just leukemia alone, there's a lot of things about leukemia that we didn't talk about, but please take a look at those figures and tables on leukemia. You've got a quiz this week, so wrap up your discussion boards, take the quiz, and as always, I will see you guys online in the discussion board. Send me questions by email if you have any. All right, over and out.